I would now like to introduce Dr. Melanie Nana. Melanie is a diabetes and endocrine registrar and obstetric medicine academic fellow at Guy's and St Thomas's and King's College London, whose current work investigates the consequences on children born to women with severe hyperemesis gravidarum. She's going to chair us through some cases with comments from our expert panel. Melanie?
Brilliant. Good afternoon, everybody. It's an absolute pleasure to be here in Trinidad today and to talk you through some cases. So I will be swift because I appreciate that we're running quite behind. But the intention is to talk through some obstetric medicine cases that we've looked after in our hospital and to talk through some of the principles about the way that we think about these patients within the multidisciplinary team within the obstetric medicine networks. So you recognise all of our panel here who will contribute to the discussion. So I'll just wait for the slides. Brilliant. Okay, so two cases. So the first is a 32-year-old para 1 lady. So she's got a new diagnosis of granulomatosis with polyangiitis at 13 weeks gestation, which was previously called Wegener's disease. And she had presented to Wales, which if you imagine the UK is the left side, on the side of England, which is where I trained in medicine. So she presented at 6 weeks gestation and had with nasal congestion and stuffiness, had a biopsy which suggested vasculitis. And her only other symptoms were that of left MTP, so the first metatarsal joint, pain and stiffness. She had the following investigation, so she was anchor positive with a C-anchor pattern and a PR3 antibodies of 125, which would suggest aggressive disease. Her renal function was normal, her urine dip was normal, and she had no hypertension. And a chest x-ray showed a nodule on the left apex with small cavitating lesions. And it was discussed within the multidisciplinary team in Wales about the appropriate management, and it was decided that she would be started on 20 milligrams of prednisolone and that she would be given weekly review. So during this period, she was stable. Her CRP was 14. So you'll remember from Kathy's talk that, yes, our changes in pregnancy, but CRP doesn't. So this is an appropriate measure, and the patient remained stable. However, at 28 weeks gestation, she presented to the hospital with headache and vomiting. Because of the headache and vomiting, most people will assume that a patient has a clot in pregnancy if they present unwell, and she therefore had a CT scan to rule out a venous sinus thrombosis. And it was suggested on that scan that she then went on to have an MRI for further delineation, and it was demonstrated that on this scan that she had a neurohypophysitis. So in view of these MRI findings, she had a pituitary function test, and you can see here that she had a suboptimal response to shortstenactin, she had secondary hypothyroidism, and her FSH, LH, and prolactin are in keeping with pregnancy. So at this stage, she also had a repeat chest x-ray, which showed now multiple bilateral rounded nodules, predominantly apical, consistent with GPA as well. So she now has multi-system disease. So at this point, she was started on an increased dose of prednisolone, 90 milligrams, and a decision was made to transfer her from a West Wales hospital into the one tertiary centre in South Wales because the plan was, this patient's very poorly now, we're not quite sure about the medications, and should we just deliver this patient early to try and facilitate appropriate treatment? And that's when I got a phone call, and I always know when someone asks my advice that it's not my advice they want, it's Professor Nelson Piercy's. So they knew that I might be in touch with her, so they called. And over the next 24 hours, we facilitated in a multidisciplinary team with the teams in Cardiff and the teams in Bridgend, which is where the patient was being managed, and 3 physicians and an obstetrician in London. So we won't do too much audience participation in the interest of time today, but I just want you to have a think about this. So we keep coming to the thoughts of what would you do if she wasn't pregnant? What are the risks of giving her treatment? What are the risks of this untreated multisystem GPA? And when should she be considered for delivery? And who would you want in your team to be involved? So I'm going to talk through some of these principles to give an idea about how within the multidisciplinary team we were thinking about this patient. And you can see on the right-hand side who was made up this multidisciplinary team, which was partly from Wales and partly from England. And you can see we had an obstetric physician, rheumatologist, a chest physician, and an obstetrician. And in terms of what would you do if this patient wasn't pregnant, I've just put here the BSR, which is a British rheumatology algorithm for how you would manage and induce remission in a patient with this sort of vasculitis. And you can see here that the options are that you would induce remission with cyclophosphamide and glucocorticoids, or with rituximab and glucocorticoids. And the other option, which had been decided within the multidisciplinary team prior to that, is that you give a high dose of steroids. And then we had this other notion floating around of should we deliver the baby and then be able to aggressively treat this patient. So I'm going to talk you through these thoughts because this is kind of how we were thinking about it. So cyclophosphamide. So Professor Nelson Piercy mentioned previously that we do use cyclophosphamide in pregnancy, particularly for breast cancer. We know that it's teratogenic in the first trimester of pregnancy, and you can see here, I've highlighted that in baboons, so in animal studies, 25% of cyclophosphamide does cross the placenta. However, it's not teratogenic in the second and third trimester of pregnancy. And therefore, Professor Nelson Piercy and two of colleagues in obstetric St. Thomas's Hospital have used this for autoimmune rheumatic diseases and respiratory diseases in the second and third trimester of pregnancy. And the short and long-term outcomes for these patients are reassuring. One of our collaborators, Professor Amant, has done some very interesting work on the long-term outcomes of the children who are born to chemotherapy agents, which are very reassuring. So ideally, we would stop these drugs 35 to 36 weeks to allow the bone marrow to recover prior to delivery. So that's cyclophosphamide. So if we think about the other side of the algorithm, we have rituximab. Now, rituximab is slightly different. It's an IgG1 molecule. It's a big molecule. And it therefore can't passively pass the placenta. It has to bind the neonatal Fc receptor, which is in the placenta, to cross across. Now, bear with me, but this is a part of the placenta here. And you can see that these Fc receptors are only upregulated between 13 and 16 weeks gestation, which means that the drug can only pass after the first trimester of pregnancy, and then it can reach the fetal circulation. That means that it doesn't pass the placenta in the first trimester of pregnancy. And so again, we feel empowered to be able to use this drug in the first trimester. So we have to be careful because it will suppress the B cells for 6 months post-delivery, so which is why we favour cyclophosphamide in the second and third trimester and rituximab in the first, because you have that period of washout before delivery. So what about high-dose steroids? I think the first most important thing to say is that there are no evidence to suggest that there are adverse fetal effects from steroids, most particularly not cleft palate or palate in humans. And this doesn't matter whether it's oral, inhaled, nasal spray, or dermatological administration. So steroids are safe in pregnancy. However, we need to think a little bit about the physiology. And I think this is one of the really things that I enjoy about obstetric medicine. You have to go back to the pathophysiology. You have to go back to the pharmacology of the drug and think about how this is going to affect the pregnancy. So you can see here, and Professor Tilak-Sung is an endocrinologist like me, so finds this exciting. So unfluorinated glucocorticoids, these include methylprednisolone, prednisolone, and hydrocortisone. This means that they're broken down by a placental enzyme, 11-beta-HSD2. And you can see, therefore, because of the inactive metabolites, only 10 to 20% of this drug will pass into the fetal circulation. Fluorinated glucocorticoids, however, are not broken down by this placental enzyme, and therefore more of the drug crosses into the placenta. So when we're thinking about treating a woman and their baby, if we are looking at maternal disease, as we are in this patient, we would want to use one of these unfluorinated glucocorticoids. If we're trying to do fetal lung maturity, then obviously we want the baby to pass, the drug to pass into the fetus, and therefore we would use a fluorinated glucocorticoid. And this is part of a review article that we wrote on the management of COVID-19 in pregnancy, because this is particularly in the UK, we were using dexamethasone typically, but in pregnancy we opted to use prednisolone. So we were applying the pharmacology of the drugs and the physiology of pregnancy to make the most appropriate choices. Now, Saying that high-dose steroids are safe in pregnancy, they do have some increased risks. So they increase the risk of gestational diabetes. You can see here that in large doses, they increase the risk of premature rupture of membranes. And if you give doses of above 10 milligrams for a long period, they increase the risk of significant infections for the mother. So think back to those initial decisions about giving 90 milligrams of steroid to try and avoid rituximab and cyclophosphamide and what the complications therefore might be. So the final question was, should we deliver this patient early to facilitate normal treatment? Then she won't be pregnant, and then we can just do what we think is most appropriate. And the answer to this is clearly no. So preterm birth is associated with increased risk of respiratory distress, neonatal intensive care admission, jaundice, and special needs. And you can see that the special needs education demand goes up significantly when you get below 37 weeks gestation. So it might get you out of a sticky situation to deliver the baby early, but it's not going to help the baby in the long term. So these were the MDT discussions. So it was recognized that the patient and the baby was at significant risk of morbidity and mortality if the disease was suboptimally treated. Because the patient was in the second trimester, she was given cyclophosphamide. The prednisolone was weaned. Despite that, she developed gestational diabetes and was treated for that appropriately. She was transferred to a tertiary centre because it was felt she would have access to a co-located neonatology department. And it was decided within the multidisciplinary team that on no terms should this patient be delivered before 34 weeks because the risks of prematurity far outweigh the risks of cyclophosphamide. So this patient delivered her baby by maternal request cesarean section at 36 weeks gestation and had a healthy baby boy. So this is a really complicated case. I learned a lot about autoimmune vasculitis during this period, but I think it goes to show that patients with severe medical diseases in pregnancy should be managed as if they are not pregnant, because that's the general principles that we went back to here, that are increasing confidence in the use of immunosuppressants in pregnancy and indeed many other medications. We were talking about the use of growth hormone antagonists the other day in clinic, and even since we had written a review article 2 or 3 years ago, the wealth of data is increasing phenomenally. So we need to just go to the literature each time to make sure that we give the patient all of the information. Multidisciplinary team working is of paramount importance. And these are complicated and unusual situations. And I think if there's one thing that I've learned about some of the leaders in the field, it's that phoning a friend is absolutely the right thing to do almost every time. So we have an expert panel here who may have some comments. So I'll open the floor about any comments that you may have. Ingrid, it looks like you do.
Just speaking. No, into the microphone. Speak into the microphone.
My question, sorry. Why was she delivered at 36 weeks and not later?
Good question.
Okay, so let's start with what would have happened if they hadn't rung Melanie. If they hadn't rung Melanie, she would have been kept on high-dose steroids and she would have been delivered earlier than 34 weeks. They were ready to deliver her at 28 weeks. So she moved to the tertiary centre in Wales, and they reluctantly agreed to give the cyclophosphamide. They gave the cyclophosphamide, but they still weren't comfortable, and they still thought they should deliver her early. And I completely agree with you. She should have been delivered at 39 weeks as any other elective cesarean section. Yeah. But she wasn't our patient. We were advising from afar, and it was a compromise. I wasn't about to get into an argument with an obstetrician, and in any case, it was the obstetrician's decision. Yeah. But I think the case is complex, but it illustrates how they were so paralyzed by the pregnancy that they didn't treat a life-threatening vasculitis with the appropriate drug, and that's the learning point. But fortunately, they knew Melanie, so they rang her up.
The reason I asked that question because I had a very similar patient treated the same way, delivered at 39 weeks, vaginally though. Yeah. Because it wasn't the maternal request cesarean section, and I tend not to deliver patients preterm unless it's absolutely necessary. And if you speak to your neonatal colleagues, we do have fantastic neonatal care. At the hospital I work, you look after babies more than 500 grams, even 22 weekers. If they're born in good condition, they will offer some support and even ventilate, and depends on their weight. However, we tend to forget that even though babies deliver 36 weeks in the best neonatal services, they do have risk of premature problems. And a baby delivered 36, 37 read a attainment is probably about 6% less than a baby delivered at 39 weeks. So we should not deliver babies unless it's absolutely necessary.
And if she'd had access to a maternal medicine midwife who could have spoken to her, she wouldn't have requested an elective cesarean section for maternal request.
Yeah, I think sometimes we forget that the woman is pregnant and pregnancy is normal, and that's where the midwife role comes in, where you normalize the pregnancy itself, not the disease process. But if the woman's having a normal pregnancy, you can advise. You still need to talk about breastfeeding, skin to skin, how she's going to cope postnatally, the risk of postnatal depression, all the things that relate specifically to midwifery, and that's the key with having midwives in place.
So the key for us as obstetricians is it is really important how we counsel the women about the condition that they're experiencing, and we support normalization of vaginal delivery and normalization of pregnancy as far as possible. That's part of the reason why we are here, and that's one of the aspects of advocacy that we should be putting into place.
I think it also demonstrates that we do a lot of undoing, because a plan had been made to deliver this baby at 26 weeks. And so then we're saying a change in treatment, a change in delivery time, and she went a long way before to get to that stage.
I think the other thing as well is that the women tend to get very confused. So if they see their specialist, who, I mean, someone alluded to that before, that you should have a cesarean section, especially neurology patients, cardiac patients. Most cardiac patients deliver vaginally and deliver safely. Most neurological cases, they deliver vaginally, and the woman, in terms of bringing in midwives, it's really, really important, as Sharon said, that they are treated and they are managed as you would have done normal pregnancy, providing that holistic midwifery care, breastfeeding, all the care that midwives normally do, but at the same time balancing that with their medical condition. It's really, really important.
Thank you. I'll move on. So case 2, if you could pop the slides back on. Thank you. Okay, so the second case is a 24-year-old. She's in her first pregnancy and she has a pre-existing diagnosis of idiopathic generalized epilepsy. And when she was booked, she described her triggers for her epilepsy as sleep deprivation, stress, and bright lights. When she entered pregnancy, she entered on lamotrigine, 75 milligrams BD, and clonazepam, 500 micrograms daily. And I was asked to go and see this patient when she was having a tonic-clonic seizure during her dating scan. And when I arrived, she was having her scan in the fetal medicine department, we discussed some of the risk factors that could have meant that she'd had that seizure. And this patient had stopped all of her medications and confirmation of pregnancy, assuming that they wouldn't be safe. She had had seizure control prior to pregnancy for several years, so it was normal for her to have seizures on a 1 to 2 monthly basis. And she had untreated nausea and vomiting of pregnancy, so even if she were taking her medications, they wouldn't have been staying down. So again, I want you to have a little bit of a think about what you would do with this patient and what would the panel do. I'll also have a, shall we discuss now or shall we carry on and come back? Carry on. Okay, so this patient, what I would have liked to do is admit the patient to hospital to give her some antiemetic therapy and to give her IV antiemetics in the meanwhile and to restart all of her anti-epileptic drugs. But I think as Dr. Clark demonstrated that the patients, we have to have a conversation with the patient, and it has to be what the patient wants to do too. And she was not in agreement with any of this plan. So she was not keen to start on any anti-epileptic drugs. She most certainly didn't want to come into hospital. So then we started having a conversation, which I think we have been really, really fortunate to learn from one of our specialist epilepsy nurses in our hospital about the safety of sleeping alone, having a partner, making sure that you're bathing safely. So I went through all of that discussion. But she was not going to come into hospital, but she did agree to start back on her anti-epileptic medications. And so they were started, safety advice was reiterated, and I arranged for her to be seen in our joint epilepsy clinic the next week. So as this patient's journey progressed, it was very evident that she was a vulnerable patient. And we are, as I mentioned, extremely fortunate to have a fantastic epilepsy specialist nurse, Jen, in our hospital, and she was able to contact her by telephone a couple of times a week. it was clear that we needed a multidisciplinary input for this patient, and spent many, many hours discussing the safety of the medications. Her nausea and vomiting was treated aggressively on 3 antiemetic therapies. And I think, this was just one tiny part. We'd spend a lot of time counselling patients about nausea and vomiting of pregnancy. As Professor Nelson-Piercy mentioned, the thalidomide disaster has really tainted not only clinicians' views of antiemetics and therapy, pregnancy, but also the patients. And so it takes a long time to persuade a patient that it's appropriate to treat her nausea and vomiting of pregnancy aggressively. She had barriers to accessing care, and therefore DNA'd multiple of the appointments that we made for her. And we used lamotrigine levels in pregnancy in our hospital. They were persistently subtherapeutic when she had them checked. And she then represented in labour at 37 plus 4 weeks gestation. She had had a seizure at home, was 5 centimetres dilated, and had an instrumental delivery, which we know is extremely high risk. So she did agree to going on to some additional clobazam at 10 milligrams once daily postpartum. But despite the efforts of this multidisciplinary team, this is a patient who it was difficult for her to access this support. So I just want to take through some messages about epilepsy and pregnancy, because the prevalence is high. It's the most common neurological disorder in pregnancy, and 1/3 of women with epilepsy are of childbearing age. And the risk of death, you might have seen in the EMBRACE report, is 10 times the risk of a non-pregnant woman with epilepsy. And you can see here, if you look at the EMBRACE data, that 17 maternal deaths happened between 2019 and 2021 in women with epilepsy, 14 of which died of sudden unexplained death in epilepsy, giving a mortality rate of 0.63 per 100,000. Now, these rates were similar 2016 and 2018, but they've doubled since 2013 to 2015. So have a think about what's changed during that period. The main difference is that we are trying to ensure that women of childbearing age are not taking hard-duty drugs such as sodium valproate, and we have now very good safety data for other drugs such as lamotrigine and levetiracetam, which is fantastic. However, the pharmacokinetics of those drugs mean that we have to manage these patients very closely with the support of a neurologist, with the support of an epilepsy specialist nurse where possible, to make sure that these patients do not have adverse outcomes. So this is the MRHA guidance, which are typically quite cautious in terms of discussing the safety of these medications, and you can see that they appropriately say that 1 in 10 babies with valproate will have a malformation. However, they go out there straight out to say at the top here that women who are taking lamotrigine or levetiracetam have the same risk of malformation as the background general population, which is 2 to 3 in 100 babies. So this is a fantastic opportunity for us to be having women who are taking these drugs to be on safer medications. But look what happens in the pregnancy. So you can see here, this is the pharmacokinetics of these drugs. Essentially, as your plasma volume increases and your renal and hepatic clearance goes up, the doses of lamotrigine drop dramatically in pregnancy. And we go back to the point about having physicians or maternal medicine obstetricians who can understand the pharmacology of these drugs in the context of the physiology of pregnancy. And you can see that, therefore, to be able to treat these women appropriately and to have the good therapeutic levels, they need to be on 2 to 3 times the amount of lamotrigine than they were when they got pregnant. So think about our lady that came in who stopped all her medications because she didn't want to take any. Then you have to persuade her not only do you have to take them, you have to take 3 times as many as you were taking before. So the lessons for us were, we don't wait for the drug levels. They're very useful in guiding management, but they take 2 to 3 weeks to come back in a hospital, and I know they probably aren't available everywhere. And again, we call for advice when needed. This is of particular relevance to medical registrars like myself, who haven't got so much training in obstetric medicine, who may be seeing these patients coming into the medical assessment unit having seizures and thinking, well, I'll refer them to their neurologist. I think we need to do education to make sure that we let them know that it's okay to ring that neurology on call, because this is an emergency. And this is another patient in our hospital. It's a different patient, but you can see at the beginning of pregnancy, her lamotrigine levels were 4.5. By 18 weeks, they dropped so significantly, and the dose that she was on initially was 250 milligrams, and to maintain the therapeutic dose, she needed 350, 400, 425 milligrams of lamotrigine to keep the therapeutic doses the same. But look what happens postpartum. they go up significantly again. So we need to not only be looking after these patients during their pregnancy, but making sure they've got appropriate follow-up, or at least that they know that they're going to need to down titrate these medications during a period of time which is stressful and that they're sleep deprived. So we've talked about the pharmacokinetics of pregnancy. We know that more women who have epilepsy stop their medications in pregnancy than any other medical condition. It's thought to be about 40%. So they need to know not to do it beforehand. Nausea and vomiting of pregnancy is common. 80% of women will suffer from it. 3% will suffer with hyperemesis gravidarum, and we need to treat the vomiting very aggressively, whether that's because they have epilepsy, because they have HIV, or because they're taking steroids for Addison's or hypoadrenalism that are time-critical medications. These are the antiemetic therapies, and we published the new RCOG guidance yesterday, and they outline all of the antiemetics that we can use in pregnancy. These are all the common ones that you're familiar with, and they are all safe in pregnancy. And Ondansetron, even in the first trimester, metoclopramide for more than 5 days if necessary. And as part of those guidelines, which are freely available on the Royal College of Obs and Gynae website, we have now developed algorithms for emergency medicine, for primary care, and for inpatient gynecology units to try and standardize the care, which is something I think we've talked a lot about developing guidelines today, and they need to be singing from the same hymn sheet so patients aren't getting different advice in different places. Sleep and deprivation are common in a woman who is pregnant or postpartum, so we need to think about the risks of them having seizures during this time. And we also need to focus on pre-pregnancy counselling. Ingrid mentioned this before, and I think these are some unpublished data of ours, which are very small numbers, but you can see here that we compared the patients who are seen in Professor Nelson Piercy's clinic who have pre-pregnancy counselling for epilepsy. We talked to them about not stopping the medications, the need to increase the dose in pregnancy, and this reduced the seizures in pregnancy and the number of peripartum seizures significantly. And again, we were talking about the rates of, in the literature, it says that 4 to 5% of patients who have, less, 3 to 4% will have a seizure during their labour. In our unit, it's about 8 to 9%. These are high-risk patients. So whatever we can be doing in terms of preparing these patients in the pre-pregnancy period is important. And finally, I probably don't need this slide anymore after Dr. Clark's talk, but I think it's one thing talking about contraception and actually opening a conversation. But if you're a medical registrar like I was, I hadn't discussed contraception with any patient prior to doing that job. And I think there's a lot to be said about the terminology. You know, we can say you cannot get pregnant while taking this medication because they're on valproate, for example. That's very different to you must not get pregnant, because if they think they cannot get pregnant, go straight ahead. And barriers to accessing care. I think Dr. Clark's covered this so eloquently that I won't comment further, but this patient had multiple opportunities where she did actually manage to have the care offered, but we weren't doing it in the right way. It's all very well to say these patients are difficult to access, but I don't think that's good enough in these situations. So I'm going to leave you with a take-home message, which this is another vignette from the Embrace report. Women with learning difficulties had increased seizure frequency in the first trimester. She had discontinued her lamotrigine over concerns it might harm her baby. She was referred to the emergency department by her midwife because of a self-reported increase in seizure frequency. No changes were made, and she was referred to her GP. She was risk assessed in relation to her seizure, and the GP recognised that she was at high risk of seizures, and we know patients that are at high risk of seizures are at increased risk of SUDEP and their consequences, and a referral was then made from the GP to the neurologist, and she died of sudden unexplained death of epilepsy 2 days later before seeing a neurologist or an obstetrician. And I think this just goes to show clearly we're working in silos, and until we're able to bring in those maternal medicine obstetricians, the obstetric physicians as the project managers, so that we're not bouncing patients around all of our different services, that is what's going to be needed for us all to pull together, regardless of which background we're from, to improve the care of these women.